Good afternoon, colleagues. Welcome on this lovely Monday to Deep Dive once again. Today, I am your chair and host, CPO Baloy, based out in Cape Town, and we are in for a treat. So, before we get going with the real meat of today, allow me to take you through some housekeeping. Firstly, Blood Assay Foundation.
Okay, CP, we might be having some
as driving excellence
technical.
platform. We're working and SASETs, which session is Melinda, who've helped put all of this together. Remember once again that all our sessions are recorded, and you can find these under the resources tab of Blood SA. Please remember to mute yourself during this presentation unless you want to actually ask a question. There are CPD points available, and these will be submitted automatically. You need to attend for at least an hour and make sure we've got your correct details in order to facilitate all of this. All right. We do have a mailing list, so if you're not on already, please once again go on to resources, subscribe to Deep Dive on the Blood Assay website. There's also a QR code available should you need it. At the end of the presentation, we will provide a survey to you. Please, we do encourage you to complete this as this helps us provide relevant and high quality content in the future. All right, looking forward to the future. The first thing I'd like to highlight is the National Cell and Gene Therapy Conference, and that'll be happening at the end of October. And we really encourage you to go onto the website and sign up as quickly as possible. There's a lot of exciting things happening, and we know we have our own working party, which is doing some really good work in this regard. And indeed, in October and early October in Cape Town, we have Hem-Onc happening once again. We anticipate that we should have record numbers this year, and you can help us make that happen. So you still have a chance for late registration up until the 5th of September. Please make a note of those dates. Next week, we'll be chatting about the multidisciplinary management of bleeding disorders in women, and I think this affects more than half of our population. There's a lot of good clinical pearls to pick up next week, so please stay tuned for that. And bring us today to our VIP, a man who needs no introduction, who's got more papers than the amount of years I've been alive easily, and and continues to be a shining light and really a world leader in this field. So I would like to introduce Professor Johnny Mahlangu, who is based in Johannesburg. You can have a full read of his very summarized bio sketch. Ultimately, he's got a real interest in bleeding disorders, and he publishes a lot. And so we will learn today from his vast expertise and experience. And I would encourage you to please ask him the very vital and relevant questions that we have. I think there's a lot of unanswered questions and a lot of challenges that we face in this space. And Prof has assured me he is very willing to engage in these discussions. So without further ado, I would like to hand over to Professor Mahlangu.
Thank you very much, Dr. Baloy. And I will share my screen. You're able to see my screen?
We can see your screen. If you could just switch the display so that we can just see the slides only and not your notes.
Okay. I am going to try this again. See if we can show this. It worked earlier on. It's Murphy's Law, eh?
Indeed, indeed.
Okay. One more time. Let's see. And then we can swap around. Is that better?
We still need you to just go to this. Ah, that's not perfect. That is working perfect. Thank you so much.
That is perfect. Thank you very much again, Dr. Baloy, and good afternoon, colleagues. Over the next 1 hour, I intend to take you through the foundational evidence for the activated prothrombin complex concentrate and perhaps share some of the principles I use this product in the era of non-factor therapies. And perhaps to just assure you that this is not a nostalgic, retrospective legacy review of an old product. It is indeed a necessary review, particularly in 2026, where we are faced with a fairly large number of novel therapies, and there's been some controversies as to whether we should be using products such as an aPCC. Perhaps before the science, just a brief word on my disclaimer and disclosures. This session is supported by Takeda through Blood SAA, and I want to assure you that the content and the voice in this presentation is my own. You can blame me for every line, every sentence that you hear from me. Furthermore, perhaps to remind you that I do a lot of clinical trials reflected here in my disclosure, and you will see that, in fact, many of these sponsors do produce products that are relevant to these presentations. And I'll try to give you a balanced view without any bias in my presentation. Now on to today's agenda. I've got 5 questions. The first question perhaps that I want us to answer is, what does an aPCC mechanistically do, and what is its contemporary role across a number of clinical scenarios, across immune tolerance induction, in the management of acute bleed, in the surgical setting. And then I'll sort of come to the finality, which is, I think, the essence of this presentation. What is its role in the era of non-factor therapies? Perhaps let's begin by asking a simple question. In 2026, why do we need bypassing agents? And many of you know that I like to start my presentation by reminding yourselves and myself of the patients we look after. We look after patients who are born with inherited bleeding diathesis, in this case characterized by intra-articular bleeding, the so-called hemarthrosis. The patients then progress to a destructive phase of their lives where there is cartilage and bone that are damaged. The consequence of that is, of course, joint dysfunction. Clearly, the picture here is that of a destructive cascade. And we do understand now that that is as a result of impaired thrombin generation. So an alternate definition of haemophilia is that it's a condition that is characterized by impaired thrombin generation. And I just thought I'll show you what we mean from the in vitro perspective. This is a thrombogram, and what is shown in blue, in green, is thrombin generation in the context of someone with severe hemophilia, and in black will be thrombin generation in the context of a normal individual without a hemostatic defect. And what we're trying to do when we treat these patients is to move the green line closer to the black line. And certainly we are actually achieving restoration of thrombin generation in these patients. We do so by giving them replacement therapy. And we do know that replacement therapy is not without any shortcomings. And the most feared of those shortcomings would be immunogenicity. And I just want to remind you that in the context of hemophilia A, both plasma-derived and recombinant products are immunogenic. This is a retrospective study that was conducted by Manushi in 2014. You can see here that the frequency of inhibitors was almost double in the context of recombinant products when compared to plasma-derived products. When we undertook the CPET study 2 years later, that data did not change, perhaps emphasizing that one is dealing with both plasma-derived and recombinant products which are immunogenic. There might be, of course, a slight difference in the immunogenicity of these products, with the recombinant products 87 times more immunogenic than the plasma-derived product. But in the context of this presentation, I want to emphasize that whatever replacement therapy you are using, literally you have a choice between two evils because they are actually both immunogenic. So how common is immunogenicity in the context of the patients with hemophilia? This is old hat for many of you. I just want to remind you, up to a third of these patients will develop neutralizing antibodies against factor VIII, in contrast to only 1/10 in the context of those who are deficient in factor IX. Inhibitors are high affinity IgG1 antibodies that neutralize the clotting factor. And I would like to think of the risk factors for inhibitors in the context of those that we are unable to change, in other words, the patient-related factors, and those that we can and are able to change, the so-called treatment-related factors. And the patient-related factors are many and won't go into those today, but they include gene mutations, race, ethnicity, age, family history, and less understood but important would be the immune response gene, and of course the major histocompatibility factors, in addition to the milieu of other epigenetic factors, including the interleukins and the tumor necrosis factor. The treatment-related factors are very well understood. We do know that the regimen that you use may well be contributing to the presence or the absence of immunogenicity. The danger signal and the treatment tag, which I alluded to in the previous slide, whether you are dealing with a plasma-derived or a recombinant product, that matters in fact in the context of the risk factors that one is seeing. So inhibitors are never merely a lab abnormality. They do carry a measurable cost to humans. Just to remind ourselves that, in fact, the presence of inhibitors are associated with worsened clinical outcomes. Amongst those will be the shortened life expectancy of the patients, the increased risk of intracranial bleeds, and that is not a joke. In fact, I've yet to come across an inhibitor patient who has not had an intracranial bleed. The increased risk of orthopedic complications as well as other general surgical complications when these patients need surgical intervention. And of course, they are treated with bypassing agents which impose an economic burden to these patients. And of course, that has a negative effect in the quality of life of these patients. I'm showing here the quality of life of the patients as measured by the EQ5D5L compared to those without inhibitors in green. The patients with inhibitors in yellow and orange show worsened quality of life across all categories or domains of the EQ5D5L. of course, is calling upon a change in the treatment landscape for these patients. And how has that treatment landscape evolved up to today? The timeline is particularly important in this presentation because it is actually the spine of this presentation. In the upper part of this, I'm showing what we use for acute bleed treatment in those patients with inhibitors. There are essentially three products: activated prothrombin complex concentrate, eptacoc alpha, and eptacoc beta recombinant factor 7, which is activated. At the bottom part, we saw no movement whatsoever in instituting and certainly maintaining prophylaxis for these patients for a long time, except when we were using an aPCC. And suddenly, after 2017, we have seen this exponential increase in the number of non-factor therapies, amongst which are emicizumab, concizumab, fitusiran, mestacimab, mimate, and you can continue to name the ones that are currently in the preclinical space as well as those are in phase 1, phase 2. So there's clearly an imbalance between what we use for the acute treatment and what is and we're using for prophylaxis in this patient. And the question, of course, that one could ask at this stage, the crowded prophylactic agents at the bottom, could they be compatibly be used for these patients when they do have acute bleeds, which are currently being treated with the agents at the top here? And I would like to answer that question by saying, in fact, that is the subject of the presentation today. And the answer is yes. One should and in fact can use any one of these products. In that context, I want to specifically focus on the activated prothrombin complex concentrate, and you'll see later why I want to focus on that. So let us examine what actually the activated prothrombin complex is. It is a very complex mixture. It's not a single clotting factor, deliberately balanced mixture of pro and anticoagulant zymogens, active enzymes, and cofactors. It is precisely that compositional complexity that allows it to bypass the missing step in the coagulation cascade, leading to the thrombin generation. You will see here that, in fact, some of these molecules are in relatively small amount and others are in relatively large amount. But that is the essence here, is that you don't need a specified amount. You need the whole molecule, the whole mixture to be able to use this particular product. So what does the product really do or achieve when it is infused? And I want to remind you that all of these products have got a single goal, and the goal is to generate thrombin. So an aPCC is no exception. Shown here in these three patients' thrombograms, you can see that they are all able to generate thrombin. And in fact, the essence here is that thrombin generation can happen somewhere between 15 and 30 minutes after the infusion of an aPCC. That is actually very important. And of course, what is equally important is that one is able to bring down the thrombin after it has been generated to normal levels for that individual anytime between 8 and 12 hours. And that is also important because persistent elevated thrombin generation is just as undesirable as the absence of thrombin in someone who's bleeding at the end of the day. To understand this, let me walk you through the mechanism of action of an aPCC, and I'd like to think of it in 3 stages. The first stage is when one is generating a prothrombinase type complex. This prothrombinase type complex triggers thrombin generation and early clot formation. The second phase is the role being played by the zymogens and the procoagulant enzymes to amplify into a genuine thrombin best, the thrombin best that I referred to in my previous thrombogram. And then the third part is the role of the natural anticoagulants, including protein C, protein S, the role of tissue factor pathway inhibitor, that then guards against excess thrombin generation. Where does the aPCC act in this cascade? For those of you who might not recognize this is the old cascade, including the intrinsic pathway, the extrinsic pathway, and the common pathway. The aPCC, in fact, has been well characterized and shown to act in all of these three components of the coagulation cascade. This was work that was done by Peter Shuricek, and it's work that I have yet to see being disputed in the literature as not being true. What is the mechanism of hand that an aPCC is able to act? It's actually able to act across a number of sites within what we understood to be the old or the classical coagulation pathway. The strategy, in fact, is to apply that in the context of the clinical scenarios. And I want to introduce you to the three common clinical scenarios we face in the treatment of this patient. The one is our attempt to get rid of the inhibitor. We use a strategy called immune tolerance induction. The second one is whether patients bleed as a result of trauma or spontaneously. So we want to manage that acute bleed. And the third one is our effort to normalize the lives of the patients and prevent bleeds before they happen, the so-called prophylaxis. And you will recognize and see here that the role of an aPCC, in particular the bypassing agent here, is to pair with a number of other hemostatic agents in executing all of these functions. Whether it is an immune tolerance induction, you can combine a bypassing agent with factor replacement therapy or non-factor replacement therapy. If you combine a bypassing agent, we can also use that in the context of an acute bleed management. And of course, it can be combined with non-factor therapies, as I alluded to. Now, let us begin with what happens when we do combine an aPCC with immune tolerance induction. And I want to remind you that this is actually work that has been done for a long time. And the goal of immune tolerance induction is to restore the effectiveness of the replacement therapy for acute bleed, surgery, and prophylaxis. Its ultimate role is obviously eradication of the inhibitor. And it's able to do so with a very high success rate of 70 to 80%. And that actually has been established for a long, long time. And that high success rate, in fact, should be encouraging us to use this molecule in the context of patients undergoing immune tolerance induction. Of course, there's been a number of protocols which have included an aPCC in immune tolerance induction. And these have not been standardized, I must admit. Several of these protocols will pair an aPCC with factor replacement therapy. Some of these protocols will pair an aPCC with non-factor replacement therapy, as in the case of the bone therapy, which combines an aPCC with factor VIII, and the Atlanta protocol, which combines emicizumab together with an aPCC. But it turns out that it's not just the eradication that is important, it's also the timing of the eradication that is important. And I want to remind you that, in fact, prompt initiation of immune tolerance after the diagnosis of inhibitor may increase the likelihood of success, regardless of the initial antibody titer. And this is actually shown by these two graphs here. If one looks at the time when you start immune tolerance induction just by a month apart, those which did not start early were worse off than those which started early. And those that had a lower titer, of course, were much more successful than those which had a higher titer. But the bottom line here is that timing matters in the context of immune tolerance induction. So how do you protect these patients from bleeding while they are undergoing immune tolerance induction? What I didn't mention is that immune tolerance induction is not a procedure that you undertake overnight. It takes usually a couple of months, a couple of weeks, and in most instances, a couple of years before one can see the result. And I want to remind you that that combination of an aPCC together with either a factor replacement therapy or a non-factor replacement therapy has actually stood the test of time. It can and has been used for the treatment of acute bleeds in patients undergoing immune tolerance induction. So whilst they are receiving immune tolerance induction, one can use a bypassing agent such as an aPCC. You can also use it in the context of course, the bond regimen, where these patients may well be just be getting factor as part of their regimen, but the addition of an aPCC would, of course, accelerate that process. And I want to emphasize again here that perhaps the most important data comes from the fact that 90% of the bleeds, when an aPCC is used in immune tolerance induction, they are actually reduced in the patients that are undergoing immune tolerance induction. You could also argue that does this actually happen in real life? The answer is yes. In fact, if one looks at the data that was published some time back, it might look very dated, but it's actually very instructive. This was published a couple of decades ago, but I think the outcome of that data still hold true today. The bottom line is that the pattern between 1977 and 2019 has been consistent. There is reliable inhibitor elimination generally favoring the outcomes when an aPCC was used. In fairness, this evidence may well be coming from very small series of patients. You can see here it's a case report. Here only 21, 81, 15, and 22. The bottom line is this data set, in fact, has established the way we approach immune tolerance induction using an aPCC to date. There hasn't been further data that has been generated here. That actually concludes my sort of illumination on the role of an aPCC in immune tolerance induction. It is a critical role indeed. I want us to move now to the role of an aPCC in the acute bleed management of patients with inhibitors. And I'll start this by showing you that there were 7 studies that I put together here, including just in excess of 1,050 acute bleeds in 260 patients with haemophilia complicated by inhibitors. What is clear and what is visibly clear using this bar graph is that the aPCC was effective in achieving hemostatic efficacy in a fairly broad range of outcomes, from 62% to as high as 96%. Why does that not surprise me? I think it's just a reflection of the heterogeneity of the bleeds in these patients. It is indeed not a reflection of the hemostatic agent that was used in the patients. And of course, we accept that efficacy is but one measure. And the question that we always ask ourselves is, how quickly can bleed control be achieved using an aPCC when the patient has an acute bleed? This slide here shows that the majority of the bleeds from these 3 studies were achieved, in fact, were controlled with 2 or less infusion. You can see that the success rate, roughly 80% of the bleeds, in fact, were controlled with 2 or less infusion. That is important. It's particularly important as we contemplate the treatment burden that the patients will experience if they had to treat for more than 2 infusions, the treatment burden imposed to the caregivers and the healthcare system. And I want to perhaps move on to the next phase, which is the PHENOX study that talks to the surgical approach using an aPCC. But before then, the question that we should be asking ourselves is, are these 2 bypassing agent recombinant activated factor 7 and an aPCC equivalent in efficacy? And that was the essence of the PHENOX study. It was a prospective head-to-head randomized crossover open label study that enrolled patients. And I think the elegance of the study, in my view, was that the patients were their own controls. So an individual would have acute bleeds and be treated with one product. In the next bleed, they would be treated with a different product. In that way, one could eliminate a large number of confounding variables and biases associated with both intra and interpatient variability. Perhaps to point out in this PHENOX study, you should note the high bar that the investigators put. Essentially, to show equivalence, they, at the beginning of the study, indicated that there should be 15% or less difference between an aPCC and a recombinant factor 7. And we'll see later whether one was able to achieve that or not. But perhaps importantly is also to point out that there is a slight difference between similarity and equivalence. What this graph shows very clearly is that if we are treating episodically using an aPCC or recombinant factor, one could see similar efficacy rates across the treatment modality. Shown here, of course, in blue will be the aPCC, and in black would be the recombinant factor 7. However, the criteria for therapeutic equivalence in this particular study, the PHENOX study, were not met. In other words, the difference between the two were more than 15%. That does not take away, and I think from the message of this presentation, that in 2026, one should go back to this particular graph and ask the question, can one use either of the bypassing agents in the management of acute bleeds in our patients who are exposed to non-factor therapy? And the answer, at least in my view, based on this data set, is yes, one can do that. But perhaps before we jump into that discussion, let's look at the disconcordant pairs that were considered during the conduct of the PHENOX study. And to summarize this data set, I want to say here that the single most clinically important finding that emerged out of the PHENOX study was that nearly a third of these patients were successful with one or the other bypassing agent, particularly early in the course of the treatment of the bleed. That discordance is not a caveat only for our convenience and for analyzing the PHENOX study. It is actually the one that has informed the guidelines, such as the WFH guideline, that basically calls for individualized therapy of the patients. It is also a biological justification for us to use one product or the other when faced with inefficacy of one product or the other. So efficacy questions aside, let us now turn to the clinical challenge, which is the challenge of surgery in patients with inhibitors undergoing surgery. I want to emphasize here that the success of surgery in inhibitor patients is not just dependent on the presence of the hemostatic agent, it is also dependent on the competency and the skill set and the experience of the multidisciplinary team, and of course the facility where the patient is undergoing surgery. Do they have a critical care facility, a 24-hour coagulation lab, and a pharmacy that is able to respond when there is a demand for additional hemostatic agents? And the bottom line here is that one is able to carry out the procedure if you meet not one but all of this in a particular center. Historically, how has surgery been regarded? And I want to remind you that in South Africa, we are very much familiar with 1994. I will tell you now that that's when we had the demographic South Africa being born. At that stage, in fact, surgery in inhibitor patient was a no-go. You were advised and being discouraged to undergo any surgical procedure in the patients with hemophilia with inhibitors. And you fast forward to 2026, that has actually changed completely. In fact, if anything, would like to take the patients to surgery because they don't bleed, because we want to improve their quality of life. So that has actually made this practice has made its way into the current guidelines, the 2020 WFH and the ICH guidelines that we use today. What about the surgical data? The CEF study, in fact, was the one that brought to the fore for the first time the real-world observational surgical data. This was a study conducted in 19 centers around the world, and 24 patients across congenital and acquired hemophilia with inhibitors were included in this study. It reached in excess, in fact, if one looks at the average titer level was as high as 4,250 Bethesda units in some of the patients. Dosing in this particular study was left at the discretion of the treating physician. And in fact, that was a good thing, because then these particular results will then reflect the real world experience rather than reflecting in any way a protocol dictated approach. So did this patient actually fare, and how did they fare in the CEF study? You will see here that the CEF study, 91% of the procedures were rated as excellent or good overall, and that the figure, in fact, held even in the context of those patients who were considered to be severe risk. They also fared very well when they were subjected to surgery. And just to remind you that the severe risk category comprise up to about 40% of the patients. So efficacy is a very important outcome of the CEF study for those patients undergoing surgery with inhibitors. What about safety? If one looks specifically at the adverse events during the CEF study, and I want to be precise here that, and specifically refer to causality, there were 35 procedures and only one serious adverse event, in fact, was noted in these patients. This was an AV fistula that had a clot in it, and it was judged as possibly related to an aPCC. The rest of the other 34 procedures, in fact, did not have serious adverse events attributable to an aPCC. Intraoperative efficacy in the CEF study was, in fact, very high at 94%. And I find this very reassuring for a population that was considered largely to be inoperable in the past. So the CEF study is just a confirmation that in 2026, you can and should be able to operate on inhibitor patients without any fear that it will be inefficacious and or unsafe for the patient. Let's examine the safety outcomes in more detail. You can see here that there were no adverse events that were attributed to the immune tolerance induction, and there was no amnestic reaction that the patients experienced, in fact, when they were receiving an aPCC. And that directly addresses the theoretical concern many of us have and have been carrying around for many years, that repeated exposure to an aPCC may well compromise the outcomes. It wasn't the case, in fact, in the case of the CEF study. So the CEF study is a single study. The bottom line is, are there any other experiences outside this particular study? And the answer is yes. This is data that was presented at EHEAD about 5 years ago. I'm not sure why it was never published, but the bottom line is the data looked specifically at a very large number of articles that were published in Medline and PubMed, 645. The full screening resulted in 87 of these articles. 50 were excluded, and surgical hemostasis in this patient, in fact, was evaluated in 14. And this is the data from the 14 studies that were put together. The long and the short here is that in 14 publications reporting 100 major and 162 minor surgery, hemostatic outcomes were rated as excellent or good in more than 90% of the major surgeries and 98% of the minor surgery. So outside the CEF study, there is clearly a fairly large amount of data supporting very good surgical outcomes in patients undergoing surgery with inhibitors using bypass agents. We are well established in terms of the principles of surgery. Surrounding this, of course, is the reality we face today, is that the protocols are changing. And I want to revisit the triangular connection that I showed you earlier on, that for the patients undergoing surgery, immune tolerance induction and acute treatment, we are now increasingly using non-factor therapies for these patients, whether it is a combination of non-factor therapy with other hemostatic agents, breakthrough bleeds, treatment with other hemostatic agents, and non-factor therapy, or non-factor therapy in the prevention of bleeds. It's the reality that we face at this stage. And of course, there's been events that have happened where the combination of non-factor therapy together with an aPCC has resulted in unmasking unheard deleterious effects and certainly adverse events such as thrombotic microangiopathy and, of course, not unexpectedly, thrombosis. And I want us to revisit some of those studies, in fact, that unmask that. Specifically look at the studies of emicizumab, the HAVEN program in inhibitor patients. These are actually the data taken directly from the publications. You will see that breakthrough bleeds are a reality in those studies. They range from as low as 37% in HAVEN 1 to as high as 71% in many of the patients that one sees. Just need to find my way out of here and close that. So you can see that, in fact, we have to deal with breakthrough bleeds in the era of non-factor therapy. And of course, the patients receiving the emicizumab in the real world with breakthrough bleeds showed actually the same results as in the clinical trial, from 5% to as high as 61% in some of the patients. Up to a third of these patients, in fact, required surgical intervention in addition to having breakthrough bleeds that one needed to treat. And I want us to perhaps remind ourselves that we do need bleed management guidance in this context that allow us to be able to manage these patients with real and in fact, concrete problems that they face. Let's go back to ask basic questions. Where do these patients bleed if they do bleed whilst they are receiving by non-factor therapies. This is data that has been taken from both the Haven program and the Explorer 7 program. You'll see that 70 to 80% of the patients, in fact, still bleed into the joints. You'll recall my very first slide, I showed you hemathromatosis, and that is the hallmark of hemophilia. You'll see that 71% of the patients in Haven 1 had intra-articular bleeds, and 75% of the patients in Explorer 7 had intra-articular bleeds. And the reality one has to face is that a large number of these patients, 44%, in fact, were not treated in the Haven program. And almost half of these untreated bleeds actually were intra-articular bleeds that one could potentially be able to manage. And I want to remind you that we do need both bypassing agents. I made that point earlier on. For 30 years, almost 30 years, the medical community has had access to both of these bypassing agents. They are actually essential for individualization and personalization and optimal management of these patients. In the era of non-factor therapy, my impression is that that should not change. We just need better bleed management strategies and strategies on how to manage the potential deleterious effects of combining the bypassing agents with the non-factor therapies. And I want to show you perhaps examples of those where the combination was better than a single agent. This is a published case study that was published at ASH. The bottom line here is that this is an individual, an infant, 13 months of age, who was not responding to a recombinant factor 7 at normal standard dose, had to be switched to an aPCC for hemostasis to be achieved. Similarly, this is another case of an adolescent individual, 13-year-old, who did not respond to eptacoc beta at 225 micrograms per kg and maintenance dose of 75 micrograms per kg, but an addition of a different bypassing agent at admittedly low dosing of 25 to 50 units per kg resulted in control of these patients' bleeding diathesis. So the long and the short is we do need both bypassing agents in order to manage acute bleeds. We certainly need the bypassing agents in order to manage patients undergoing surgical procedure. So the improvement in bleed resolution we observed in each of these patients after they were switched to an aPCC, which is slightly different from the initial hemostatic agent that was used. And I want to take you through this evolution that we are undertaking at the moment, the evolution of how we choose our hemostatic agent. When we published the first WFH guideline, essentially we wanted to use one product or the other. And that was the advice that we gave in that guideline, the 2009 guideline. We then revised that when we published the 2020 guideline. In the 2020 guideline, we're quite clear that we're actually dropping the aPCC in favor of the recombinant factor 7. Remember, 2020 was just the beginning of the era of non-factor therapy. And we advised that the aPCC, if it was used, it had to be used at a standard dose of 50 units per kg and no more than 100 units per kg per day for the treatment for the patients. You fast forward beyond 2020 to 2024, 2026, we have better experience, and certainly we can give a slightly different advice to the 2020 WFH guideline. And the bottom line here is that we still need and use the recombinant factor 7. The reality on the ground is that we need to put in bleed management guidelines that allow us to be able to manage the patients in the event recombinant factor 7 does not work. And that is what I want to take you through. That analysis we did last year, and that was published in RPTH. And I just want to go back here to the data on the use of the aPCC in the Haven program. This is now Haven 1, 2, and 4. These are Haven programs in which the patients had inhibitors. And this was a pooled analysis that we analyzed. When we did the analysis, specifically, we looked at the cumulative dose, the period after the dose was used, and we made certain conclusions. The first one, I think, which was very, very important, is that 81% of the bleeds, in fact, in the Haven program were treated with an aPCC within 24 hours. And when that was done, there were no thromboembolic events and there were no thrombotic microangiopathies that were observed. One could also make a second point here is that seemed to align with the data that we established earlier on, that we could and should be able to use an aPCC in scenarios where the first bypassing agent does not work. You'll recall that is the data that I showed you earlier on. And if one looks specifically at the individuals post the usage of the aPCC, one could also make a point that the dosing that was used was actually in the region of 50 to 100 units per kg in any given 24 hours. So we've learned our lesson that, in fact, if you stick to this dosing regimen, one is able to avoid the thrombotic microangiopathy and the thrombosis in the patient. In about a quarter of the patients who did not actually use the dosing within the limits that I indicated in the previous slide, who use more than 100 units per kg in any given 24 hours, these individuals actually developed thrombotic microangiopathy. And you'll see that, in fact, where it was used more than 100 units per kg in every given 24 hours, this is where the two of the three thrombotic microangiopathies occurred in the patient. And the lessons learned here is there are bleed management guidelines that we should stick to. But perhaps flipped, one could also surmise that 96% of the bleeds that were treated successfully with an aPCC, in fact, were treated without any thrombotic microangiopathy or thromboembolism associated with it. And that, to me, is the reality of the analysis that we did. In fact, that data was published in RPTH. If you want to go and read it, the first author is Robert Sidonio. And the data, in fact, is quite clear that the usage of an aPCC in the setting of non-factor therapy should be considered and certainly should be allowed, provided you stick to the dosing recommendations of less than 100 units per kg. And I want to perhaps give you real-world examples of cases where that has been the case. This is a case that was published in 2018 in an individual with a spontaneous bleed with a perirenal hematoma. And the patients actually use a lowish dose of an aPCC, 15 to 25 units per kg, and there was no deleterious effects and certainly no unexpected adverse events. Another case, these are actually two events. Case number 2 and 3, 2 trauma-induced bleeds in patient number 2 and a spontaneous bleed in patient number 3. They did not respond to standard doses of recombinant factor 7, and they were, and in fact, the frequency was escalated over a very long period of 6 to 10 days. These patients were then switched over to a second bypassing agent, an aPCC, at a dose of 10 to 15 units per kg, and you can see that there was a response. And case number 4, spontaneous bleed in a patient with an iliopsoas hematoma. There was no response to recombinant factor 7. This in case is eptacoc beta at a loading dose of 225 and a maintenance dose of 75 mics per kg. And the patient was then switched over to an aPCC without any deleterious effect. And I must emphasize here that the bottom line is not the outcome. The bottom line is being very much vigilant whilst you're using a combination of an aPCC with non-factor therapy. If you stick to less than 100 units per kg, you'll be fine. There should be no issues, in fact, and no unexpected results, as exemplified by this particular 4 examples of real-world cases. I want to leave you with 3 principles. The first principle is that one should be able to preserve therapeutic choice. Responses to bypassing agents are very heterogeneous, particularly in the light of what I showed you in this presentation, that the discordance between the 2 molecules in the PHENOX study, in fact, you could predict that 1/3 of the patient will need the other molecule in order to treat the bleed. The second principle is that one needs to individualize the treatment. So match treatment to the clinical context. And I've shown you examples of immune tolerance induction, acute bleed management, as well as surgical management, including the CEF study, where the use of an aPCC with non-factor therapy is possible and should be considered. And then the third principle is that there should be an element of discipline when one is using the additional bypassing agent in sticking to the bleed management guidance. And if you do stick and remain within the recommended limits and assess regularly, you should be fine. In fact, you can assure the patient that they should be fine. So an aPCC remains an important and effective bypassing agent across immune tolerance induction, acute bleed management, and surgery. But its contemporary use for non-factor therapy does require individualization, it does require prompt assessment, and it does require strict control of the dose and the duration of the dose in the patients that require an additional hemostatic agent. With that, I would like to stop here and hand you back, Sipiwe, and I'm looking forward to answering questions. Thank you very much.
Well, there you have it, folks. You will not get better at ASH. That's all I'm saying. So we really thank you for that, Prof. That was really enlightening. And I think we definitely have already learned quite a lot. And you've touched on quite a few important things that I think we can chew on in the next couple of minutes. So colleagues, we are opening the floor to questions. While you're thinking about what you want to ask, I would... Maybe I'll go to the chat. Looks like people are already jumping in. All right. So Jacques first had a question just to talk about the breakthrough bleeds in patients without inhibitors on emicizumab. I think you had a slide on that, eh?
Yes, I specifically focused on breakthrough bleeds in the patients with inhibitors. But you will recall, and some of you may not know this, Haven 3 was the phase 3 clinical trial in those patients without inhibitors. And yours truly from Johannesburg happened to lead that clinical trial. The breakthrough bleeds in those patients were not different from the breakthrough bleeds in the patients who had inhibitors. They were somewhere in the region of about 40 to 50%. We published that data in a pooled analysis called Haven 1 to Haven 4. And the first author was Culligan. It was published in Blood, if I recall correctly.
Thank you. I think we'll all go have a look at that if you haven't already. Dr. Bailey is thanking you for a fantastic talk. The question is around, is there a role for pharmacodynamic studies when using aPCC in patients with inhibitors?
No, thanks very much, Janik. It's a question that some of us have had when we went into the field, and it's a question that we continue to be asked, in fact. The downside, of course, of many of these hemostatic agents, and in fact, it's getting worse, is that one is not able to replicate their pharmacodynamic effects in the lab setting. We've come to accept that in many instances, in fact, those don't exist. But having said that, Janik, we are beginning to experiment and accept that the global assays may well be the proxy for us to understand what the impact of these molecules are in hemostasis. Not so much the pharmacodynamic, but more of the pharmacokinetics that we're able to measure. In my very first slide, I showed you the thrombogram. That thrombogram was generated in the context of that understanding that if one is able to use global assays such as thrombin generation assay, one is able to some extent to predict the extent to which one is able to generate thrombin and of course adjust the dosing according to the level of the thrombin that one is able to generate.
Thank you for that answer. Jacques from the Free State, Vrystaat. Hey, how significant is the risk of the anamnestic response to factor 9 when using aPCCs in patients with hemophilia B with inhibitors?
Well, thanks, Jacques. I'm glad you asked that question because that is a question that is always at the back of our mind. And perhaps to contextualize this for the listeners here, aPCC does have a small amount of factor 9. And the significance here is that when the patients are going to develop inhibitors, they will initially show an anamnestic reaction, then, of course, the development of an inhibitor. It is significant. It's an important clinical sign that you must look for. But I think what you are really asking is, what is the risk of an anamnestic reaction when you're using an aPCC? The risk is, as I showed in the presentation, repeated exposure to aPCC did not increase that risk of anamnestic reaction. And that is, to me, that is important. I mean, if you don't get it first time, there is very little chance that it will appear later on.
That is actually very helpful. Next question is from Dr. van Staden. And as broadly to yourself as well as any other clinicians in the field or in the audience who would like to answer, is how does one do or perform a safe immune tolerance induction in the pediatric setting? I think that's if I'm reading that correctly. And how effective are these ITIs? I think it might be also important for us to find out how practical is this in South Africa, I was trying to ask around. I currently maybe might be able to name 1 or 2 people who've ever done this. What are your thoughts, Prof?
No, Dr. van Staden, you're asking the most difficult question. No, many people, and I can count hands, that talk about immune tolerance induction have actually not undertaken it. It is hard. It is expensive. It requires resilience. It requires dedication. And to answer your question, how one does a safe immune tolerance induction? I'm not sure what you mean by safe immune tolerance induction. The only risk that I see with immune tolerance induction is the risk of breakthrough bleeds whilst the patient is undergoing immune tolerance induction. And I have shown you data that you can use either additional hemostatic agents in the form of an aPCC or recombinant factor 7 to treat that breakthrough bleed. So that risk you can mitigate against. The safety in general, I haven't seen any immune tolerance induction showing, as an example, thrombosis. I've yet to see data that reports that. And if you're talking about maybe the other effects of immunomodulation, I'm not aware of those and certainly haven't seen them being reported. And in fact, I must qualify my answer. I'm not a pediatric oncologist and certainly not a pediatrician. Maybe I could leave this to the pediatrician. But in general, in countries such as Brazil, where ITI, in fact, is imposed on everyone by government, the success rate is very high. And if you try it outside protocol and outside imposition, the success rate is almost nothing at the end of the day.
Yeah, I think you've hit on quite an important topic there. Just while we waiting for maybe a brave pediatrician to put up their hand, in the context of our country with access to just factor and bypassing agents being what it is right now, do you think it's really practical to do ITI in the state sector?
Yeah, that is actually a question that some of us have debated for some time. And to be fair, not just debated, but try to put into practice. I'll give you examples of what we have done at Charlotte. We have subjected patients to immune tolerance induction in the form of modified POP, and the success rate, in fact, was 0. But I mean, admittedly, we're dealing with patients with very mature immune system and probably way after the development of inhibitors. So one could say that there were other factors that were mitigating against success in this case. But overall, our experience has been that we're not very successful at eradicating inhibitors, certainly in adults. Having said that, in 2 of the studies that we undertook, we exposed patients to a new hemostatic agent, be it a factor 8 or factor 9, and when they developed inhibitors, very soon thereafter, we put them on an ITI regimen of that same factor. And in fact, the success rate was 100%. And I'm not sure if it was because of the agent itself, or was it because the intervention was very early? And of course, as I indicated in my presentation, the theta was still very low in those patients. But we do have some experience, and I would say that it's not a lot of experience, and certainly it's not a lot of experience around the world. Where the experience exists, places like Brazil, they've got a national protocol, government makes available unlimited factor to them. And in fact, you cannot, in Brazil, put someone on emicizumab unless they failed ITI.
Prof, I don't want to dwell too much on this topic, but it is of quite interest to me personally. Is there any studies evaluating the cost effectiveness of doing ITI in the context of now emicizumab and other agents that have become available? I mean, ultimately what I'm asking, is it really worth doing still?
It's a good question. In fact, I'm aware of 2 studies. Okay. The overwhelming message out of those 2 studies is that it costs more to do ITI than to put patients on emicizumab.
Yeah, I think that was the general feeling as well. Okay. We thank you for that, Prof. We have a few other questions. Moses has asked if there's a role of thrombin generation assays in the monitoring of these patients who are also on Hemlibra and may need aPCC for a bleed.
No, thanks, Moses, for the question. It's a question that we continue to ask in the community. I'm talking about the hemostasis community. To the level at which, in fact, we are now initiating a series of standardization exercise at ISTH and the ISTH SSCs with a view of at least getting standardized protocols for the measurement. And I must admit, actually, it's not an easy subject to approach. And certainly, if I'm talking about thrombin generation in my lab, it is completely different from a thrombin generation in an Italian lab, in a French lab, in Guy Young in California's lab. So the standardization is something that is being looked at the moment. And I must admit, it's not promising because of, as you know, Moses, you come from a lab background, the variability in the operator, the instrument, the reagents, blah, blah, blah. All of those seem to murky the field so much that we're almost all paralyzed. But there is an SSC committee that is looking at standardizing thrombin generation assays. How successful are they going to be? I think yours and my guess will be the same.
Yeah, sounds like the jury's still out on that one, and that may take a while before we get a good answer. Speaking of your own lab, we have a question from Prof. Susan Low asking about chromogenic factor H testing in patients with emicizumab. And this is in the perioperative setting. So she's asked for both with and without inhibitors.
Yeah, no, thanks, Susan. It's actually a little bit of a sticky subject to talk about at this stage. And I must admit, when we started to introduce the non-factor therapies, in the first one, in fact, I used was in 2015. We were all assured that there will be no need for the lab. You fast forward 10 years later, I'm beginning to think that, in fact, we're probably wrong. And the reason is not because we want to monitor the non-factor therapy. The reason is because increasingly we are facing clinical scenarios that are so complex that we can't extricate the effect of the non-factor therapy from the complexity of the clinical scenarios. And in fact, the utility here of things like the chromogenic assay will not be so much to change the management of hemostasis. It's actually to manage the expectation from those who are basically throwing everything at it and saying, well, I was on Hemlibra when X happened. I was on Hemlibra when Y happened, etc., etc. And that is the context in which I'm beginning to think that we do need many of these assays, the chromogenic assay being one of them, the thrombin generation assay being the other one, and a whole host of other assays that one can think of just to differentiate the problem from the solution. And I think, in fact, the non-factor therapies are the solution. And unfortunately, when you hit the problem, often you mix the solution and the problem together.
Yeah, I think that's fair. So she's appreciated that comment. I think maybe you can touch on Jacques' second question about doing minor procedures in patients on emicizumab. I think you've got some data from Haven about that.
Yeah, I mean, I think that probably, Jacques, is in our bag. There's endless data, both in the context of clinical trials, but real-world experience, including our own experience, that shows that the majority of minor procedures do not need additional hemostatic agents. I think the data from Haven program was presented by Rebecca Tusiares in a number of papers that have been published. You can search those, Rebecca Tusiares. The real-world data, in fact, has confirmed that in excess of 80% of minor surgeries can be undertaken without additional hemostatic agent. And I must say here, our own experience, I've had patients, as an example, probably about 6 or 7 patients undergoing circumcision without additional hemostatic agents. I've had inhibitor patients not requiring additional bypassing agents. We obviously had bypassing agent on standby in case they bleed, and of course they did not bleed. It's basically applying your mind and also keeping a very watchful eye on whether the patient does or does not bleed. And of course, if they bleed, it is unethical not to treat. But by and large, the minor surgeries, you can do a lot of them without additional hemostatic agents. And certainly, if they are on Hemlibra, we have done so many times without worrying about additional hemostatic agents.
Thank you for that. I think maybe related to this topic, you did bring out a few case studies and also the FINUC trial around that some patients will respond to aPCC where they haven't responded to recombinant 7A and vice versa. Is there a way to predict who falls into which category?
Yeah, do you want a Nobel Prize, Sipiwe? I would give it to you if you came with the answer.
Okay, so that is a work progress.
We have not come out with reliable predictors of when one or the other bypassing agent fails. It looks like there may be and I don't think it's intrinsic in the molecules themselves. In other words, it's not a molecular event. I think it's individuals and the circumstances where they are. And in fact, and it applies both to intra-individual and inter-individual heterogeneity. You could have the same patient today responding to one agent, and then the next morning not responding to the same agent. Yeah, you can come and claim your Nobel Prize from me if you can come with the answer.
Something I'll definitely think about. But just in your own practice, how do you sort of rationalize? I mean, I saw those case studies waiting 6 to 10 days before they made a switch, and that gave me a bit of palpitation. So practically, what do you do in your own setting if you've got somebody who doesn't seem to be responding? At what point do you make that decision? And do you switch? Do you like use a bit of both? How does it work?
Yeah, and that's an important practical question. I think from our approach, we tend, number one, ab initio, to have access to both bypassing agent. That is important. Don't ever undergo surgical procedures if you have one or the other bypassing agent, because you will be faced with scenarios where that reliable that you've known for a long time does not work. So we tend to make certain things clear. You must have both, and we'll try the one that we are used to at optimal doses. That is important. So if we have given it in the dose that we know the patient has responded before, and it is an optimal dose, I agree with you completely. We don't wait for 5 days or 10 days. As soon as we see that the patient continues to bleed despite the optimum dose we're giving, we switch over to the second bypassing agent. That's our practice. That's the way we approach it. I can't answer, and in fact, you're right. The case studies I presented, both of them had up to 10 days of waiting. I suspect, and can I be honest, and I challenge you to go and look at the abstracts. I suspect that the patients actually stopped bleeding, then rebled, and then stopped bleeding and rebled. It wasn't a question of continuous bleeding for 10 days. Any reasonable doctor would have difficulty in defending allowing the patient to bleed for 10 days.
Yeah. I think that seems fair. I think Jacques is offering a follow-up to his initial question about what do you define as minor. So he lists a patient who had a hemorrhoid banding procedure, didn't bleed during the procedure, but then a few days later presented with massive rectal bleeding requiring transfusion when the surgeon thinks the band fell off. So, how would you comment on that?
Yeah, I mean, Jacques, it happens to all of us, by the way, and I call it surgical chromic deficiency. and no amount of hemostatic agent could actually stop it. The patient just needs to go in a stitch or have a band put back. One should separate those scenarios where hemostatic agents are truly hemostatic. In other words, they work in the hemostatic system versus surgical bleeding, which should actually be tackled using surgical approaches. Yeah. Perhaps a comment on this. In general, I'm very wary of hemorrhoids. So I tend to put patients on additional hemostatic agent for at least a period of 7 days. Reason being that you must remember the surgeon is looking at that one hemorrhoid and they are going to band one. Another one will pop out in the next 5 to 6 days, and that's how hemorrhoids develop. And when it does, you want to make sure that at least it doesn't bleed. And so the patient is covered. So I tend to be a little bit an overkill, even if it's a minor procedure. It's a minor procedure with additional hemostatic agents in this case.
Thank you, Prof. I think we need to start wrapping up, but there was definitely one question that hasn't quite come up, and that's around access. I think we're still living in sitting in a situation where a lot of these agents that we're discussing are really rather unaffordable in most settings, and the prices don't seem to be coming down. I mean, both the competent factor 7A and the aPCCs, and in fact, just general factor, you know, doesn't seem to be budging. What do you think is happening, and how can we help address this?
I mean, that's an important question, and I'm glad you're young. Hopefully, you'll take the same path as I did. When I asked myself that question in 2005, I committed myself to producing competition. You fast forward to 2026, we have actually been involved in at least 23 novel agents. The problem is most of those don't make it to South Africa. So to answer your question, one needs to create competition, no doubt in my mind, so that the economics of that can actually stabilize. The second component of it is we do need to start to rattle our own innovative juices, Sipiwe. Think laterally as to what else can we do. It cannot be that the only people who think like that are coming from the East, from India and China and Japan. To me, Africa is as rich as those countries, and we have not seen any of these products coming out of our own world. So we do need to basically innovate. And then we didn't innovate during COVID. We just need to repurpose the tools and the expertise towards innovating for the unmet needs and certainly for inaccessible therapeutics that we're looking after. And then maybe the last question is, the funders need to make a call. And my impression is that funders are not lying down. They do call the shots from time to time. They do drive the people they support towards affordable medication. And I think we're beginning to see it in South Africa. And in fact, we're going to see it much, much more in the future, where the funders will simply say, sorry, I'm not paying for product X, I'm paying for product Y, because it is X number of percentage less compared to product X.
Yeah, I think you've touched on some really big points. Jacques also chipped in. Jacques, maybe you can just unmute and verbalize what you've put in the chat.
There may be music in the background. I'm sitting in a coffee shop and listening. So I'm not sure if I'm audible. Can you hear me?
Please go ahead. You're very audible. No music in the background.
I'm gonna. Yeah, in terms of, I think one of the big issues is I think that we urgently need a robust rare disease policy in South Africa, and I mean, it's not only haemophilia, but I mean many other rare diseases, especially things like PNH and so forth. And us as a country need to come up with a strategy on how we going to fund these things. And if we, as a signatory of the WHO, we actually need we are mandated to have a rare disease policy, I think by 2028 or 2030. And I think, yeah, and I feel all of us in these sort of fields like haemophilia and PNH and all these things must continually put pressure on the government that there is such a policy. I mean, I'm sort of thinking that one should have a central rare disease fund where not every medical aid contributes a proportion to that, and the state contributes a proportion to that, and then there's a because one understands, like, if you've got these very expensive therapies, it's difficult for a single hospital or a single funder to pay for these medication. But if it's sort of the risk is shared through all, it may be possible. But yeah, I think we urgently need such a thing in our country. Innovative ways to access therapies, I think.
Absolutely. No, Jacques, thanks for your brilliant thoughts. And I think maybe I could make 3 comments, Sipho, if you allow me. One is Jacques should be joining the Rare Disease International. He'll be a very nice asset to that organization, because that's exactly what they're looking for, enthusiastic individuals who think broadly about rare diseases. And certainly the second one, Jacques, is it's not so much the policy, it's the implementation that we need. Now, if you think about it, the WHO resolutions, there are many of them. The WHA resolutions, there are many of them. The WFH resolutions, there are many of them. What I'm not seeing is translating those into actions on the ground. If we can find a way of just implementing 1% of the resolution and see it grow, to me, that will make a difference at the end of the day. And then the third comment is your thought around funding rare disease at an innovative level. BHF, the Board of Healthcare Funders, is already on that bandwagon. I don't know if you've been invited to these meetings. I've been invited twice to these meetings. They are looking at alternate models for funding, and they're certainly making some progress. They're not getting 100% buy-in, but they're making some progress. And if you drop me an email, I'll be able to send you some of the documents that they've produced. Absolutely, absolutely innovative, amazing, with a view of increasing access and of course, affordability for these rare conditions.
No, I think thank you very much. Yegelin has also suggested maybe we negotiate as a bloc in SADC, similar to the EU. But I think we've run right on time, and this has been a very enlightening and educational session. I really appreciate the input and definitely the interaction. And we look forward to having you back once again, Prof, sometime in the future.
Well, thanks very much. Thanks for inviting me.
Okay, and thank you everybody for joining. Please remember to like and subscribe and leave a review on the link that's going to come to you after we close the meeting. Thank you and enjoy the evening. Goodbye.